feeding is something that is not allowed in pediatrics. So I don't think we can force PAP on patients. But the way I see it is, it's probably a potentially helpful strategy if you can figure out how best to use it. And I think the Schlapping story, at least based on what we've seen with the 9036 study, if you can replicate that in other tumor types or other studies like what we have now, with 2511 and the open randomized phase 3 study that was done in smokers, if that truly is a predictive biomarker, then you can go back and select patient based on SLAC. Now, the challenge is we don't have a validated cut point. Lawrence assessment was just based on presence of SLAC. So if you have 1% expression, they consider you positive.
If you look around, the best biomarker for PARP in response to PARP inhibition is, BRCA mutation. Even in that group, if you objectively look at it, the responses are reasonable, but nothing really breathtaking, not like ALK inhibition or EGFR even. So if you look at the alterations in DNA repair pathways in lung cancer, there are many, not just one, but many of them I think are all the epiphenomenon rather than the causative one. So it's very hard to argue that it is a disease where you have a single defect, they can be synthetically lethal. So I remain skeptical of all these biomarkers.
Yeah. So the other line of evidence will come from sub-study G. Unfortunately for long-term, we haven't really struck gold yet with everything we've tested. So maybe here we'll be lucky because that study now we can enroll 30 out of the planned 60 patients. So, and there will be an interim analysis after the first 20 patients in the subset to decide whether or not it's a worthwhile strategy. So, I think the future is very close for this strategy, whether or not it's going to move forward or just stop.
So it's called triumph of hope over experience.
Well, that's
Well,
always the case. Yeah, always the case.
I would add that I think that it may not be the home run of a TKI in an oncogene-driven tumor, but there are clearly, certainly in small cell and probably in non-small cell as well, a subset of tumors that are highly dependent on DNA damage repair pathways. And I think identification of those, with perhaps Schleffen-11 being the marker, maybe there are better markers, I think is key. But we also have had now a good amount of experience with the PARP inhibitor olaparib combined with temozolomide, and we presented our phase 1 data earlier this year, and more to come. But we're finding that's a very well tolerated combination with really very good activity. And I think that especially in a disease like small cell, where a lot of our options are not very palatable for reasons having to do with toxicity and quality of life, I think this is a really nice option with clear activity.
And to add to that, I'll say that, and it may not be the same populations, but when we talk about ipi/nivo as potentially having a role because there's some activity, I mean, in this, there's some activity potentially, and it's well tolerated. And that's, to me, the big distinction between those two groups. It may be that two different subgroups benefit most from those two different lines of therapy, but the fact that it's tolerable, to me, makes it worth exploring.
And I also want to bring up this whole issue of all these PARP inhibitors are not the same. So we had the same problem. I think, Ram, you talked about it, or somebody said we had some shitty drugs. Who was using the word? Okay, so there were some drugs that were out there. Was it the RET or the ROS?
Ben started with feces today.
So. Okay, so I can remember some technical jargon. So within PARP inhibitors, of course, there was, if you remember, gosh, you've been working on this for 15 years, and this class has come and gone. And in 2008 to 2010, every big drug company sold their PARP inhibitor. So as you know, Pfizer sold their PARP inhibitor to Clovis, which is now rupicatinib approved. Schering sold their PARP inhibitor to Tesaro, which is now niraparib, and Tesaro is worth $6 or $7 billion US, selling hundreds of millions of dollars in the ovarian cancer space. And then one of these was sold to BioMarin, which then sold it to Medivation, which came back to Pfizer, which is talazoparib. So I think it's important when we look at classes of drugs that we should not get confused. There may be a drug, maybe it's talazoparib, because some people believe that this PARP trapping is important. So there is something with talazoparib. this may all be a bust. But surprisingly, PARP inhibitors have got 2 labels for ovarian now. When there was a lot of skepticism, sat in meetings just like this where they said it was just a waste. And they got 1 label in breast. And actually AstraZeneca almost threw away their PARP inhibitor. Then they got a new CEO. He pulled it out of the shelf, took it to the FDA and got a label. No new trial was done. And now Lynparza is selling hundreds of millions of dollars. So I'm optimistic. He's not. Let's see where the future comes.
So I would have a question with regard to the whole DNA repair group of drugs. Is your skepticism only for PARP or other DNA repair, ATM, ATR?
DNA PK. Yeah.
So it
PK.
depends on the
Yeah.
drug and the group, right? So again, I think the issue is we all should be agnostic and go with where the data is. But I think the ATR inhibitors are interesting, both biologically and pharmacologically. So I mean, it's certainly a valid thing. But the question is, we need to find vulnerable population. We just have a hard time identifying the right population.
I think you're absolutely right. Just looking at the populations, Rafat, great talk on mesothelin, and I know it's been a Herculean task. But tell us about the KRAS targeting T cells. At the NCI, Rosenberg was doing it. They got a great paper in the NEJM, I think in a brain tumor or something else. Do you think that can help in mesothelioma? What are you thinking?
For lung cancer, it could, but again, as they pointed out in the paper, I think that particular mutation is very, very uncommon. So it is a rare KRAS mutation, and then they have to find the T cell against that. So I think it will probably benefit some patients.
But it's a T cell from the patient that
targeted.
recognizes that mutation, that they expand ex vivo
Yeah.
and then give it back to the
Yeah.
patient. It's almost like a TIL,
Yeah.
but TIL that is designed
Very
to recognize a specific mutation.
Exactly.
But they've had a couple of great responses, right?
Yeah. Again, it's going to be a small number of patients, so I think it will take some time to catch on, but we need to have that particular mutation and find the T cell that will recognize that. But again, that's a very small population, but clearly you can get great response. So we don't see, in mesothelioma, we don't see the KRAS mutation. And in terms of the KRAS mesothelin targeted agents, is basically indirect therapy. You could use a mesothelin targeted agent such as the vaccine and combine it with other KRAS inhibitors. But most of those trials for KRAS mesothelin are basically mesothelin targeted agents, just picking up a population which happens to be KRAS. So we have not been able to figure out the biologic basis between KRAS mutation and mesothelin. A few years ago, I met with Frank McCormick about 3 years ago, and his impression was that it doesn't matter what it is, you just target mesothelin, then we'll figure out the biology. But I think the biology between mesothelin and KRAS is not well understood. It's very complex. Ira tried to study it, and he said, I will do other things.
Even though we have KRAS mutant models, you can correct me if I'm wrong, but the KRAS may be an initiating event, but you need several additional events to cause disease progression. So maybe along the way, there is some other event that causes acquisition of overexpression of the mesothelin that happens. It just so happens.
But also, we are not sure about that. It could be an epiphenomena, whatever, because all pancreatic cancers are KRAS mutant, and they all express mesothelin. So whether there is how it gets turned on, we don't know. So I'm not sure.
I want to bring up this whole issue of MET. Remember a few years ago, Genentech had an antibody called METMAB, which was like antibody. They selected a group of patients. I think it was FISH or IHC, I can't remember, that were MET overexpressing. There was a lot of optimism. This is 2011, 2012. A big trial was done. And I don't think that would have been published. Maybe it's been published, but it was negative. Now we are looking at these exon 14 skipping. Ultimately, the whole end result is more MET in the cell, correct, Jürgen?
Yes.
Because it's not degraded as quickly as normal MET, so it hangs around. Sort of the same thing as MET amplification, where there's more MET, except a different way to get to more MET protein, whatever the MET is doing. you are showing some responses. Monotherapy, durable, 12 months, 14 months with a kinase inhibitor. But MET-MAB never had a single response. I mean, their monotherapy data was negative. So any thoughts about MET? Because this has been one of these teasers. It teases you. You feel there is something. You spend $100 million. And you don't have anything. So
my comment is that, of course, sometimes small molecules have advantages.
Or antibodies.
I think we know this from the EGFR mutation story. It's the selectivity comes from the mutation, possibly. I would think that the MET exon 14, I expect a pretty high response rate, which is already indicated. I am a little bit skeptical about c-MET amplification.
So you think that getting more MET protein because of exon skipping is more of a marker of MET addiction than just having more DNA copy number of MET?
Yeah.
Ultimately, you're targeting a pathway that the cell needs to survive, right?
This would be my interpretation at the moment. But again, even c-MET amplification has is apparently the amount of expressed protein for some reason
It's not that much.
for which was basically the target for MET-MAP is not the most important aspect, or that's how I interpret it.
Alex, what do you think? I mean, you did some of this work on.
So the issue with the MET-MAP program, phase 2 positive, phase 3 negative, and then the interest died in sort of investigating antibodies against MET, and then the TKIs came, and we have efficacy in crizotinib, capmatinib, tepotinib, etc. But I do think there's probably still a role for antibody-directed therapy, and maybe I know we talked about the limitations of ADCs, but AbbVie has a MET ADC, and so does Hengrui. So in both states, so there's data now for patients who have developed acquired resistance to a prior MET TKI if they have MET exon 14. They can develop these kinase domain mutations. You do TKI switching, and you can rescue them. But even in those resistant samples, when you do IHC, they're still highly overexpressing for MET. So assuming we have a good MET-directed, large molecule, I think that's something to look into.
And these small molecules, just like the Grisso, you think there's a real opportunity with them in that small subset?
Yeah, so the only thing is, we haven't really seen response rates up to like 60 to 80%. We're kind of seeing the ballpark of like 40%, 50%. I feel like MET, is sort of different in terms of a driver and a phenotype compared to EGFR, ALK, and ROS1. And it actually may be much more aggressive. So my worry beyond objective response rate is also progression-free survival. Certainly, what I've seen with patients on the crizotinib trial is that we have second-line MET trials for them, but very few are able to get onto a second TKI because some of them can progress very quickly and have really explosive progression, leptomeningeal disease, so they take a dive very quickly. And to begin with, these patients are already older. They have more comorbidities. There's a higher proportion of smoking. And so I think it's just a different field altogether.
There's also data emerging for MET kinase fusions. And
so just like the RET fusions, you're seeing some MET fusions?
There are MET fusions.
Yes.
So they'll be fusing with what what the partner genes are? Or?
TPR.
Yeah, I think we are looking now into a pediatric program in brain tumors. That's where they have especially a significance, yeah.
But these are found in lung cancer. So the TCGA found a MET fusion. Bob Doble, I think, has a case that responded to a MET TKI. But also very interestingly, I think MET was first discovered in the rearranged state it was a mutagenized osteosarcoma cell line. So it was first found as a fusion. They're just not as common, obviously.
All right. Tail end.